It's a real life.
Okay.
Will you start, sir? Real life.
Yeah.
You'll start, sir?
Yeah. Let's start.
Yes.
PowerPoint is not coming. PowerPoint is not coming.
So whenever you tell, I'll change the slide, sir.
No, that PowerPoint I'm not able to see.
Acha.
Yeah, now it is coming. Yeah, now it is coming.
Right.
Welcome, welcome to all dear students with good evening and me and there is a Dr. Rajesh sir, who is a medicine faculty. I am Dr. Devesh, who is a pathology faculty, and we have decided that we are going to conduct medicine and pathology integrated course for the students on the YouTube channel so that we can have more clinical correlation with the pathology. And in that scenario, we have decided this month with cardiology integrated series, and you can see on your screen the dates are visible here. On every Monday night 8 p.m. we are going to integrate some beautiful cases. Like you can see now, we are going to discuss about rheumatic heart disease, then we are going to discuss about myocardial infarction, then next week we will be having cardiomyopathy, and next to next that we are going to discuss about infective endocarditis. So stay tuned with us. We are going to discuss, and definitely it is going to benefit you. Share the link with your friends so that they can join us. And welcome again to the Unacademy platform. Please, Rajesh, sir, you also comment something about this.
Right. So, like, because our pattern of exam is going from NEET PG or the NEET to next. So, keeping that particular motive to help the students, we are coming up with this integrated series wherein we are integrating the pathology with the general medicine. Majority of the topics of your general medicine, they are completely in correlation with your pathology. So that is the reason why every Monday we have come up with the integration of the medicine topics with the pathology topics. So today we are starting with the rheumatic heart disease. In this particular rheumatic heart disease, this will be the overview of our presentation. That includes etiopathogenesis, diagnostic criteria we will be discussing, and in the diagnostic criteria, we have a modified Jones criteria, which I'll be discussing, clinical manifestations, and finally, we will conclude this particular session with the treatment. So first now, Davis sir will talk about the etiopathogenesis.
So, dear students, as we all know that this rheumatic heart disease is a kind of autoimmune disorder, as you can see on your screen. It's an autoimmune disorder. Why it is an autoimmune disorder? And remember, I'm going to discuss about that thing, why it is an autoimmune disorder and who is causing. You can see this is by group A beta hemolytic streptococcal infection, right? In clinical parts, I will be discussing which age group is commonly affected. Usually, it is the pediatric age group. But when this group A beta hemolytic streptococcal infection comes, right? So remember, it is secondary to the pharyngitis only. That is one important thing we have to understand. It is not secondary to skin infection. It is only to the pharyngitis. So that is the important thing we have to understand. Beta hemolytic streptococcal infection, pharyngitis will lead to the rheumatic heart disease, not the skin infection. That is the question in PGIN already exam. So next slide, I will be telling you about the why it is called as autoimmune disorder. Next slide, sir.
Right. So before going into the next thing, I just wanted to mention one point here. As sir have mentioned very clearly that it is secondary to pharyngeal infection of the streptococcus, the individual will develop the rheumatic heart disease. But one difference what you have to remember is you take post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis, it is secondary to your pharyngeal infection and as well as the skin infection. So that is a very important difference what you need to keep in mind. Over to you, sir.
So it's a very correct point sir has told. When you have to understand, because this organism is for glomerulo PSGN also, glomerulonephritis also, and rheumatic heart disease also. But rheumatic heart disease is secondary to the pharyngitis only, and PSGN is secondary to both skin and pharyngitis, right? So as I was telling you, this is an autoimmune disorder, and this mechanism of autoimmunity is called as molecular mimicry or cross reactivity, right? So what is the meaning of molecular mimicry or cross reactivity? You can see here in this image, if you look at this image, right, you can see there is a streptococcal antigen, there is a cardiac antigen, and because of these antigens, if you look at the molecular structure, a streptococcal antigen molecule is similar to the cardiac antigen, right? That is why the antibody which is formed is getting confused, and now it is going to damage streptococcal antigen also and cardiac antigen also, right? Streptococcal antigen, no problem to our human body, but when they are going to damage our own cardiac tissue, that will be the autoimmunity, right? So now you can see that these are antibodies are now autoantibodies causing damage to our cardiac tissue, and that will lead to the rheumatic heart disease, right? So that is the basic mechanism. Now you can see that because of the similarity between the molecular structure, antibodies are damaging both of the structure. That is why it is called as cross reactivity. Very important MCQ which examiner will be asking. What is the mechanism of infection induced autoimmune disorder? Remember, it is not only for the RSD, for all kind of, remember, for all kind of things you have to remember, it is an auto antibody response. It is an auto antibody response where molecules are mimicking and cross reactivity is there between the antigens, and antibody will be damaging both. So in the next slide, you can see when this patient is coming with rheumatic heart disease, and suppose we are seeing the specimen or after the autopsy, what will be the characteristic gross finding? You can see in this left side, you can see there is a so many small beaded yellow color granules are present over the line of closure of the walls. So these are like a verrucae. We can describe them as a verrucae or beaded vegetations, right? So these are verrucae or beaded vegetations which are present on, you can see they are present over the surface of line of closure of the walls, right? So that is why we describe these are verrucae vegetations which is present on the line of vegetation, line of the closure of the wall. And what are these vegetations made up of? See, because of the inflammation, these are consisting of the fibrin, right? So they are fibrinous vegetation. Remember that vegetations which you are seeing here is the fibrinous vegetation. In the gross examination also, you can see the red arrows are pointing toward the line of closure of the wall, and you can see so many yellowish brown deposits are there. These are all examples of the fibrinous vegetations which are seen in rheumatic heart disease. And if you look at another picture in the next slide, you can observe that how this fibrinous pericarditis, when this fibrin is getting deposited over the pericardium, and that is leading to the fibrinous pericarditis, right? So now you can see in both the diagrams, right, you can see the blue mark you are watching here, these are all fibrin over the pericardium. And the second heart specimen, it's a little older one, and there is a fibrin. This is the older one, that is why reddishness is less. And in both cases, if you look at them, and you compare with the third diagram which I am showing you here. There is a bread and butter is over there. So this fibrin deposition is giving appearance like a bread butter pericarditis, right? So this rheumatic heart disease, gross examination, you can see vegetations along the line of closure of the valves and bread and butter type of the pericarditis. And all these are, see, vegetation was also fibrin, and this is also fibrinous deposit on the wall, right? So when you see the microscopy in the next slide, when I'm going to show you this microscopic examination, next slide, if you look at this one, right, in the next slide, what I'm showing you here, next slide, sir. Next slide, sir. So in this slide, you can see I am showing you myocardium. There is a myocardium here. You can see in this arrow, this is the myocardium, and this area is the Ashkoff-Jand cell. Remember, it is also called as Ashkoff bodies or Ashkoff-Jand cell. Remember, I have written very boldly in the above column, Ashkoff bodies or Ashkoff-Jand cells are the diagnostic. Remember, these are the diagnostic of the rheumatic heart disease, not the Anaisco cells. Here I have written Anaisco cells. Remember, Anaisco cells